So with that. So thank you all for coming today. It's my pleasure to introduce our speaker today, Dr. John Tucker, who is a graduate of Adams State and a graduate of the University of Colorado School of Medicine. Dr. Tucker completed a residency in internal medicine and a fellowship in pulmonary and critical care. He also has a master's in business administration from Temple University, and he is currently an adjunct professor of medicine at the University of Pennsylvania School of Medicine. He is also the Emeritus Executive Vice President and CEO of the American College of Physicians. And in his role with the American College of Physicians has done quite a bit to carry on conversations across the country about healthcare and healthcare reform. And so today he's going to talk to us a little bit about healthcare in the United States.
Thank you.
So please join me in welcoming Dr. Tucker.
Thank you. Now I know medical students in pizza, so I won't take it wrong if you decide to get up and go because the pizza's not here yet. But we will try to get to the pizza at the end of the talk. This really is a homecoming for me. It's a privilege. Not only did I graduate from Adams State, I grew up here in Alamosa, went to Alamosa High School, and so this is really home for me. What I'd like to do today is to spend some time with you, and this talk is oriented to the students, but I hope that there will be topics of interest to all of you. Health and healthcare is something that none of us can escape, no matter how hard we try. So I hope that you'll find something in this talk that is meaningful to you. What I'd like to do today is talk about the whys of healthcare reform. Why did we need to advocate for healthcare reform in the first place? Now, any of you have a sense about whether we have a system of healthcare in this country? And I'll answer that quickly, and the answer is definitely not. In that we have such a mix of different types of healthcare in this country that it's hard to make sense of it. And a lot of it's in the private sector, but a lot of it's in the public sector, such as Medicare insurance, Medicaid insurance, Department of Defense, the VA. There are lots of different kinds of healthcare in this country. And this talk is going to focus on one aspect of healthcare, and that are trying to increase access to healthcare through insurance reform, primarily. So we'll talk about why we need to do it. And then policy and politics. Policy means, do you have a stated position, a body of knowledge that will influence the legislatures to pass legislation that is favorable to your interests? The politics are obviously how you get that done, by working with people who are in positions of power. What I'm leading up to is the 2010 Affordable Care Act, or the Patient Protection and Affordable Care Act, the shorthand for which is the ACA. So if you go back a little bit to 2008, the 2008 general election, when now President Obama was running for election, the Democratic Party anticipated that there would be an alignment of the stars after he was elected. That alignment means having his party, the Democratic Party, in the White House, at the same time having a majority in both houses of Congress. It is virtually impossible to pass large legislation without that alignment. And we know that alignment doesn't last very long. So you have to do it in the first 2 years of your administration, remembering that he lost the House in the midterm elections in 2010. And he could not have passed this, Congress could not have passed this if he'd waited too long to do it now. So anticipating a healthcare reform, the Democratic Party had three primary issues. One was to reduce the overall cost of healthcare. And I want to show you some data about how expensive healthcare is in this country. 2 was to increase access to healthcare for those who did not have health insurance. It's hard to imagine that in the United States of America, that in 2008, that there were more than 40 million of our citizens who did not have healthcare insurance now. And what's come back to haunt him is that he wanted to guarantee choice. He found that with some of the insurance reforms, that if health plans didn't provide the minimum level of benefits, then those health plans and their doctors were excluded, and so choice was not possible. So during the 2008 election, we'll talk a bit more about this, but Senator Max Baucus from Montana was the chairman of the Senate Finance Committee. And there were 2 major committees of jurisdiction, the Senate Finance Committee and the Health Committee, that's Health, Education, Labor, and Pensions. These 2 senators were key to passage of healthcare reform. So we sent a letter to them asking that the country, including employers, share in the cost. Ultimately, this is going to cost about $1 trillion to reform healthcare. Be receptive proposals for shared responsibility. This is the individual mandate of requiring that everybody have health insurance. And the reason for this is not only that everybody is covered, but as more importantly, the way insurance operates is you mitigate risk by insuring everybody. And if you just insure those who need it the most, it becomes very expensive, and then when those who don't need it as much require it, don't have health insurance, it adds on to the cost now. He wanted a government-run insurance option. He didn't get it. What he ended up with, of course, was expansion of Medicaid, which is quite important in its own right. Notice also how young he looks in 2008, and when you see his pictures now, he has aged just like Bush did in the White House. Yeah. So let's talk first about costs. Peter Orszag was the head of OMB, the Office of Management and Budget, in the White House in 2008. And at that time, it's important to note, and fast forwarding now closer to the timing for this talk, is in 2011, the United States spent $8,500 per person in this country on health care. And I'm going to show you that the United States ranks dead last among the industrialized countries in terms of health care access, efficiency, quality, these things. Yeah. Whereas the UK only costs about a third to 40% of the cost in the US, but they rank #1 among industrialized countries in terms of the quality of health care that's provided to their citizens. And the cost of health care in the aggregate for this country are going up to the point that about 17% of the GDP in 2009 was devoted just to health care. And that's $2.5 trillion now. So we'll talk a bit later about who has skin in the game. There are a lot of people who have financial skin in health care. An irony of this is there's a famous economist at Princeton named Uwe Reinhardt, and during the severe recession in 2007-2009, Reinhardt cautioned that you want to be careful about lowering healthcare costs too much because it was a major engine in the U.S. economy at the time. So here's healthcare quality. This is one of my favorite people. It's Karen Davis, who at that time was the president of the Commonwealth Fund. Whereas I talked about cost, she focuses on quality. And from the Commonwealth Fund survey, the United States ranks last among 11 industrialized countries on measures of health system quality, efficiency, access, equity, and healthy lives. And I've given this talk a few hundred times, and I always get arguments that we have the best healthcare system in the world, but you can't prove it in terms of cost and value of healthcare. There's no question that we have spectacular successes in healthcare in this country, but if you take the entire population approaching 350 million people, you can't prove that everybody gets access to equal care. So, I'm a baby boomer, and I'm right in that prime age group where my cohorts are demanding and requiring more and more healthcare services. So we expect by 2025 that there will be about 350 million people in this country. And even in 2012, just 2 years ago, when we talked about how complex healthcare is, there were over 1.2 billion visits to physicians over the course of that year. And the public isn't very tolerant of mistakes in the systems of healthcare in terms of patient information, lots of different things. And so how to get 1.2 billion visits in a year right is very difficult to do. And part of the overall problem with reforming healthcare is just how complex it really is now. So by 2030, it's anticipated that there will be about 70 million people over the age of 65, and they'll be consuming most of the resources, as we'll get to in just a minute now. You may have seen yesterday the news that people are living the longest in American history. The CDC released those National Health Service statistics yesterday. And to that point, the number of people over the age of 85 is increasing dramatically. But as we age, we develop chronic conditions. And a fourth of Medicare patients have 5 or more chronic conditions. And this 25% consumes 75% of all of Medicare spending. So there's an intense reason to get to these people and take better care of them, manage them intensively so that we can avoid the more expensive costs of their care. Complexity. For those of you who are fortunate to have a primary care physician, in the Medicare population, a typical primary care physician coordinates care with 229 other physicians in 117 different practices. Now, that's how complex this systems of care really is. You don't see that when you're in a doctor's office, but the people behind the counter do. So, healthcare reform. We've talked about issues with cost, access, quality. So let's move on then to the political process after President Obama was elected. He took the oath of office on January 20th, 2009. And remember that in 2009, we still have not hit the nadir of the recession. That didn't occur until March now. So this wasn't the only issue on the table at the time that he was trying to reform with Congress healthcare reform. Very important point, the Senate Democratic majority was 59 to 41. Why is that 59 to 41 an important point? That's right. You can't shut off debate unless you have 60 votes to do it now. So we'll talk about how we got to that point. And whereas the Republicans have a significant majority in the House right now, the Democrats have enjoyed a majority in 2009. And that's only 5 years ago. And you think how much has changed just over that period of time. So what are other priorities? Yes, the worst economic crisis since the Great Depression. And it was severe. And this was occurring not on any particular president's watch, but George Bush took a lot of the heat for this initially. And Congress passed the TARP money, which was the first part of the bailout. This is the Troubled Assets Relief Program. It's designed to shore up the banks, big industries such as the automobile industry, restore the housing market. Big deal. But it's $700 billion that is new money. Then, after President Obama was elected, the Democratic Congress pushed through the American Recovery and Reinvestment Act, which was another $787 billion. Now, of note is that no House Republicans, not a single one, voted for it, and only 3 Senate Republicans voted for the stimulus package. That was a harbinger of what was to come when healthcare reform was being introduced. The Republicans were not going to support healthcare reform, ostensibly because of costs. And by the way, just like right now, there were natural calamities and wars. We were in Afghanistan and Iraq at the time. So a lot of competing priorities. So as Benita said, we want to talk a little bit about then what is the role of one of the stakeholders in this whole reform, and that stakeholder being my professional society, which is the American College of Physicians. And this is more than a nicety. And the professional society, and we're going to talk about this a little bit tonight with the Porter Scholars, is how do you turn a professional obligation of a society into meaningful action in order to meet the policy goals of your organization. For example, access to health care. ACP has been on record advocating for universal access to health care since 1975. That's how long it takes to get some of this work done. And to do that, as we mentioned a little bit earlier, you have to have a body of policy, and you have to learn how to do the politics so that you influence people to do what you hopefully want them to do. So what is ACP, the American College of Physicians? Well, it's a not-for-profit, nonpartisan, and that's important because we have about 140,000 members across the entire political spectrum. So you can't be a Republican or a Democrat. You have to advocate for policies that the easiest way to do is advocate for patients instead of for self-interest. Now, we anticipated the possibility and then increasingly the probability that there would be Democratic majorities in both houses, and that is not because ACP is Democratic, and in the White House because it was the opportunity as well as the obligation to try to move health care reform legislation if President Obama was elected and both houses were Democratic. So for the 4 years leading up to that election, we developed a ton of policy. And why is this important? The policies were on insurance reform, quality improvement, health information technology. There's a lot of it now. The reason that you need it is, and we'll talk about this bill, the bill is over 2,000 pages long, and it's developed by a few committees in Congress. It's may not surprise you, but when either house comes to the floor to vote, most of the people voting don't know what's in the bill. It's so big and complex that they rely heavily on their staffs to tell them vote yes, vote no. So the opportunity then is to work with the staff of what they call the committees of jurisdiction in order to get your policy interests into the legislation. And that's what we did. So who are the key players? Well, you know them, and the majority leader was Harry Reid, and the speaker was Nancy Pelosi. And their job was to get all of the votes in support of this legislation that they needed. And as we're talking about with 59 to 41, then you had to make sure that no Democrats voted against this legislation. So there was a lot of arm twisting, and I'll show you a little bit later, there were some outrageous promises made to certain legislators in order to get their vote. But they were both extremely effective, like them or not. They were both extremely effective in keeping their caucuses together for this legislation. The key players in the Senate, Max Baucus from the chair of the Senate Finance Committee, as we mentioned before, from Montana. He is now the ambassador to China. On the other side was the liberal line of the Senate, Teddy Kennedy, and this had always been his primary legislative goal. But as we'll see during the course of this legislation playing out, life happens, and you'll see some circumstances that put this legislation in jeopardy. Rule 22 in the Senate is the cloture rule. It requires 60 votes to stop debate. Well, one of the life happenings was that Senator Arlen Specter, a Republican, changed parties from the Republican Party to the Democratic Party. And so now the Democratic caucus had 60 votes. They had what they needed. And Specter didn't do, it's my state, my adopted state. Specter didn't do this out of the goodness of his heart. He knew that he couldn't beat Pat Toomey in the Republican election in Pennsylvania. So he hoped that he could change to be a Democrat, and with his name recognition, he could be elected as a Democrat. He failed. Unfortunately, he died not too long after that. There were 3 committees in the House. The Ways and Means, which is the most powerful committee, Charlie Rangel from New York, who's had his own ethics challenges, a Congressman Waxman and Congressman Miller, both from California, were the chairs of the other two committees of jurisdiction. These three committees worked together and came out with a single bill. But I want to emphasize that for these 5 committees that we were constantly working with their staffs to get the language in the bill that we thought we needed. Now here were the legislative priorities. Remember I said that there were more than 40 million uninsured. So we wanted to improve access. And as I mentioned, we've been on record at that time for more than 35 years to improve access to health care. Prevention, wellness, and public health. It may surprise you, but before this bill, if you went to your physician's office and he or she was going to advise you on prevention and health, that was not a billable activity. They couldn't bill and be reimbursed for the time that they spent doing it. Now, improving health care quality, we've already talked about where the United States ranks, and very importantly, when the primary care physician's office has all these interactions with so many other offices, how you coordinate that care becomes very important. Changing payment to accountable payment. This is one of the biggest problems with the U.S. healthcare system, is that we, for the most part, both with hospitals and with in the practice community, we still have fee-for-service practice. Fee-for-service means that if I'm doing something, I'm a pulmonologist, so if I'm doing bronchoscopies, if I can do 20 in a day, I will get paid twice as much as if I get paid 10 in a day. So there is an incentive to do more and more and more. And you can look at all the procedural specialties and see why there would be this incentive. Accountable payment means that an accountable care organization means that the whole organization accepts responsibility with a finite amount of money for the total care of that population for a period of time. If they do really well, they gain share and they will make more money. If they do poorly, then they will lose money. Now, so they have every incentive to practice well. And then value-based purchasing. Stop paying for stuff that we don't need. So if you go to a doctor's office and you have back pain, says, I think you need an MRI, you don't. And that MRI is a very expensive procedure that leads usually to more tests and more money. But from the radiology community, from the hospital community, or wherever the MRI is coming from, they're incentivized to do more and more MRIs. Yeah. So do what is appropriate for the patient. Now, I think medicine is probably the most fragmented discipline in all of this, all these activities around reforming healthcare. There's the AMA, but then there are over 100 different societies in the House of Delegates of the AMA, and they all have their own interests in it. So there's not one body that is most influential in healthcare. So you have to form coalitions. If I'm working with the American Hospital Association, the president and CEO is Rich Unenstock, I can go to one person and he's responsible for 4,000 hospitals in this country. You can't do that in the physician community. So once you have the policy and you're getting into the politics, then you have to work with these many, many different entities to get them on the same page with you, because that's what Congress listens to. That we have the support of all of these communities for a particular piece of legislation. So in the years of 2007, 8, 9, 10, that's where I spent most of my time in Washington working in these coalitions to get support for our policy objectives. Now, are there any challenges to the Congress? Well, yes, there are. By law, the CPO required that any legislation has to have a 10-year score. A 10-year score means that you have to project the costs of this program over the course of 10 years. And that's $1 trillion of costs over 10 years. And you may say, well, if I can get all this preventive medicine and all these preventive medicine wellness programs into healthcare, it's going to save a lot of money in the long run. But there's not much proof of that. So the CPO decided not to score those as savings for the program. And very importantly, which is oftentimes misunderstood, is that this legislation has to have a zero overall effect on the deficit. So in order to spend $1 trillion over 10 years, you have to find $1 trillion of savings within the budget of the United States Treasury. And you have to bend the Medicare cost curve. Remember, we said that if these healthcare costs keep on increasing, they're going to become unsustainable. So you have to bend, and that doesn't mean make it bend and go down. It really means that you're slowing the rise in healthcare spending over time. And interestingly, that has happened. Now, lest you think that when I sit down with a committee with the president of our organization and we're talking about how important we think we are, we're not alone. This is the most heavily lobbied bill in American history. Most heavily lobbied bill. There were 1,750 companies and organizations that hired 4,500 lobbyists to lobby this particular bill. 4,500 lobbyists, yeah. And you can see that as the legislation got closer to passage, the number of lobbyists went up. When I talk about savings in healthcare, you have to appreciate that in a $2.5 trillion budget, that every dollar saved is a loss in income for somebody. So everybody is out there advocating for their interests within this bill. And just devilishly complex, you know, gives you a lot of faith in your government, doesn't it? All right, fast forward. The three House committees completed the markup of a combined bill, which is the Affordable Health Care for America Act, before the 2009 August recess. Now, interestingly, the bill passed the House in November, but only by a slim margin. And it's because of the Blue Dog Democrats voting against the bill. Blue Dog Democrats are conservative Democrats, and they're particularly conservative on fiscal issues. And they felt that this was just too expensive. Now, they had originally been primarily from the South, but now they're Blue Dog Democrats, particularly in conservative states around the country now, and they were influential. Only one Republican voted for it. This was a Vietnamese immigrant congressperson from New Orleans who was primarily from the Democratic district. And he felt that it would damage his opportunities to get reelected if he voted against this bill. Now here's the life happens story with Teddy Kennedy. In August of 2009, he died. He fought a courageous battle against brain cancer for quite a while. A Democrat was appointed to replace him, and Senator Tom Harkin from Iowa became the chair of the Health Committee. The two Senate committees completed the markup of a combined bill in November, and on Christmas Eve, with the narrowest of margins on the 60-39 party line vote, they passed this legislation. So now you have a House bill that's been passed, and now you have a Senate bill that's been passed, but they're not the same bill. So bills have to be reconciled before they can be finally passed and signed into law by the president now. Now, as I said, concessions were made to certain Democratic senators to get their vote. One of the funniest ones was what they called the Cornhusker kickback, and that was in response to Senator Ben Nelson from Nebraska, the Cornhusker, who demanded $100 extra million in Medicaid funding for Nebraska in return for his vote. And Harry Reid agreed to that, but once he voted for it, then President Obama says, no way. So we got the vote changed his mind. All right, so I said that two separate bills have to be reconciled before final passage. Well, you still have 60 votes, so you should be able to do it. After Kennedy died, and they held a special election, and the special election was between Scott Brown, Republican, and Martha Coakley, who was the Attorney General for Massachusetts at the time. And everybody just took this election for granted. A Democrat's going to replace Kennedy, and lo and behold, Scott Brown won. So now you have 59 again in the Senate. So how did they sort this out? Well, you can imagine there was a lot of backroom negotiation going on. Was there a chance for a bipartisan agreement? Could Harry Reid reach out to Mitch McConnell and say, let's do this for the American public, and let's all see if we can agree on this? No way. There was not going to be any Republican who was going to vote for this in either the House or the Senate. So Democrats had to go it alone. So the trick that they used was that rather than have to go through a reconciliation of the bills in the Senate and the House, is the House agreed to accept the Senate bill unchanged. So since you had the majority in the House that you needed to pass the legislation, all the House had to do was to vote yes, and they did. And President Obama signed the bill into law on March 23rd, 2010. Now this is just one piece of legislation. There are hundreds of pieces of legislation in the Congress all the time. So you can get an idea of just how complicated and complex this is in order to get this kind of work done. So the bill, H.R. 3590, is about 2,400 pages long. And I can't imagine that anybody has read the entire bill. The first 1,000 pages of this apply to the Center for Medicaid and Medicare Services, CMS. And when they take this legislation, it has to be translated into what they call rules, which are the rules by which the regulatory agencies work. And a good example of that is the development of healthcare exchanges in 50 states across the country. It's just a staggering amount of work, and it's very complex. There have been a few bumps along the way, as you know well. One was the Supreme Court ruling in June. There was a lot of concern that there were multiple petitions to the Supreme Court to overturn this law. There was a lot of concern, since the Republicans have a 5-4 majority on the Supreme Court, that they were going to rule this law as being unconstitutional. And they almost did. But in a 5-4 decision in which Chief Justice Roberts joined the Democrats and said this law is constitutional, all of the other 4 Republicans on the Supreme Court voted against that. And Roberts used a particular trick in order to be able to do it. Rather than say that this was a individual mandate, which was one of the reasons that the proponents to throw this law out, that they did not think it was constitutional to require people to buy health insurance. But in a narrow opinion, Justice Roberts said this isn't really a mandate, it's a tax. And taxes are legitimate under the U.S. Constitution, and he voted with the minority, the Democrats, to uphold this. But one major problem with the legislation, with the Supreme Court opinion, is that states could opt out of Medicaid expansion. And Medicaid expansion is a big deal in states that have high levels of poor, and states like Texas, for example. And multiple states and Republican states, as you might expect, opted out of Medicaid expansion on ideological grounds, even though the legislation provided funding for their Medicaid expansion. They literally just refused to take the money because of ideological differences now. And you can also understand that there was just an absolutely disastrous rollout, that CMS trying to implement this 1,000 pages, when they tried to develop healthcare.gov, it did not work. And the Republicans had an absolute field day. And in November, December, January, there was a great concern that the law could not be implemented. And then slowly, after the administration hired new private expertise outside of the bureaucracy of CMS, it began to turn this around. And lo and behold, they met all of the 2013 enrollment targets. And when you think of $40 million people, $1 trillion, 40 million people without health insurance, in this first pass through the healthcare exchanges, There were over 9 million gained health care insurance, and Medicaid enrollment increased by 6 million people. You can imagine this if you're a family that hasn't had health insurance, that this was a big deal that you now have health insurance. As the economy began to improve, employers began to hire and to offer more health insurance. There's another 8 million that came through the employers. The Congressional Budget Office estimates that there will be 19 million enrolled by 2015, increasing to 25 million by 2016 now. And the enrollment period starts next month for the next year. So it's hard to say that this wasn't a success. And the politics now playing out for the midterm elections, the Republicans are having a hard time running on opposition to Obamacare because the proof is there. Having said that, the majority of the country does not like this Affordable Care Act. But the cognitive dissonance is that the people who don't like it are people who have other health insurance. The people who do like it are people who didn't have health insurance, but now have health insurance now. When you think of some of the changes in the law, for example, you cannot be denied health insurance because of a pre-existing condition. It's huge. If you lost your job, you had breast cancer 5 years ago, and you went to get health insurance, the insurance company could deny you health insurance because of a pre-existing condition. They cannot do that anymore. And that is just remarkable in terms of choice and access in health care. If you're like I am with 2 kids under 26, children now can stay on my health insurance plan until age 26. It's been a big help, particularly for parents who have children of the college age now. So what I've tried to do is to spend a little time, we have time for questions, going through the whys of healthcare reform in this country, to talk a little bit about what healthcare is like in this country. I hesitate calling this a system because it's really not. Why we need to do it, cost, quality, access. And in my opinion, the opportunity was seized at the right time to be able to do this, as unpalatable as it is to parts of the political spectrum. And importantly, that where ACP as a professional society saw the opportunity to engage with the federal government, we did so in a planned way, and we don't give money. We do this all by advocating for what we think are responsible positions now. So I think for our organization, it was refreshing, regardless of where you are on the political spectrum, to see the policy interests of the organization met in this legislation. Now, as we go ahead, remember the general election is going to be coming up in 2016, and I think it will be very difficult to roll this legislation back, because you're going to have to take on all the people who have gotten health care over the last 3 years, health care insurance now. But if both houses of Congress go to the Republicans, and if the White House goes to Republicans, then there will be an attempt to repeal the Affordable Care Act. But I think it's going to be very hard to do. Now, so I'm going to stop with that. It's 20 minutes before the hour, and I understand classrooms that people sometimes have to start leaving a little bit before the hour, but I'm happy to stay as long as necessary to take any questions and have a conversation with you. Yes?
I'm curious, in your opinion, if the changes have improved the quality of care. I know it hasn't been a long time, but...
1 year is not long enough, but let me tell you about some of the metrics that are now in place. And we talked about accountable care. Part of the accountable care with accountable care organizations is they don't get paid until they meet the quality metrics that are imposed by a CMS now. So these are performance measures that they have to meet and meet and hopefully exceed, if they're going to get paid. In larger entities, I think that there is evidence that healthcare quality is improving. Implementation of new primary care delivery vehicles, such as the patient center medical home, is another opportunity. Where we don't have many data are in smaller private practice settings, in which it's very hard to examine the practice and quality of those organizations. So there's a cautious yes, but it will take several years to know whether the law is meeting the expectation in terms of improving quality.
I have another question. I have lots of questions. So I'm curious, in many of the countries where, like the UK or Canada, where they have had, a system of healthcare, there's concerns raised by their members or the citizens that care is often slow, it's difficult to get an appointment, and then that these high-cost procedures are sometimes discouraged because of certain cost considerations. Could you address perhaps that and how that might play a role into, as we provide additional care, do you foresee that as a concern?
Well, there's always going to be a balance between the affordability of health care and the demand for services by those who want it. The National Health Service in Britain is a good example of that. It's a very interesting story in its own right, in that you can believe it, even during the period of the Blitz in the Second World War, the Prime Minister appointed a commission called the Beveridge Commission that began to plan for the provision of healthcare services to UK citizens after the Second World War. I just can't imagine that would be high on your plate, but they did. And they formed the National Health Service now. Now, the challenge with all of these countries who implemented a National Health Service, Italy was another example, is that as long as the government can afford to pay for it, then it works pretty well. But in a worldwide recession, as there was in 2008, then governments began to fray and say we can no longer provide all of these services now. So I don't think that there are very good data, but you have to take these countries one at a time. And the 11 countries that we're talking about are Sweden, Norway, the UK, the Netherlands. The country that we've had the most comparison with, of course, is Canada. And Canada ranks next to the U.S. in terms of healthcare quality, surprisingly. And you have to talk about we're talking about the entire citizenry, not just those who get a high-end or procedures now. So if you take the entire citizenry and you survey them, they are generally very happy with their primary care and comprehensive care. But where the rubber hits the road is if they say I need a knee replacement, if I don't get that next week at the Rothman Institute down the street from me that has 40 orthopedic surgeons, or are they going to have to wait 3 months to get it? And I don't think that that's a strong enough argument to change the way that they do business. Where you do want to be sure is when you have an emergent problem, are you going to be seen? I think the evidence is pretty good in the UK that you are being seen. Yeah. But for those who are accustomed to the US kind of provision of health care on demand, they're not going to be happy. That's a very legitimate question. Sir, you had a question in the corner?
Has there been any statistics of physicians, other healthcare providers deciding to retire earlier rather than really still be in the marketplace as a result of the changes?
Yes, I think there are data that show that in certain markets that physicians are retiring early, and it's primarily because of what they perceive as low pay and a high administrative burden, that their time is spent too much on paperwork and not enough time actually with the patients now. And as challenging as this legislation was, surprisingly, administrative simplification is also part of this legislation. And it's for the very reason you mentioned, is that it's a shame if somebody has 30 or 40 years of experience and they're going to give that up because it's just too hard to practice. And quite a bit of money in this legislation has gone to improve reimbursement for primary care physicians, including the prevention and wellness that I talked about earlier. Yes, and now over here too. Go ahead.
So we have an increase of people on the Medicaid. How is this affecting hospitals and other physician offices as far as like the Medicaid allowable? are hospital stuff now getting less money based off of that? Are they having trouble keeping up with that? 'Cause like, let's say they charge something for $20,000 and Medicaid allowable will going to pay, 40% of that.
Right.
How is that going to affect overall the hospital as well as salaries for physicians and employees?
Right. Well, as you know, Medicaid varies state by state. It depends on how much the state is contributing to Medicaid. For these early go-around, the federal government, with this law, is putting a ton of money into Medicaid because it wants to increase participation in Medicaid. And generally, it may seem a little bit surprising, but hospitals are generally enthusiastic about insurance expansion, both in the commercial marketplace, but also with Medicaid, because the reimbursement rates are high enough, to meet their margins. But where you have states that refuse to implement Medicaid and they're paying low reimbursement rates, then both providers in the practice community as well as hospitals are finding it hard to take care of the full freight for Medicaid patients. It varies from state to state. Sir?
So you said that you didn't think that anybody had actually read the entire legislation.
Right.
So does that mean that the ACP also didn't read the legislation?
Well, I think it depends on yeah, I think that's probably true. Because what we are most interested in are the policy interests of ACP. So I think at the level of our staff, and we have a staff of about 50 in Washington now, that the staff have read the legislation now. But if I were to say as the president of ACP read the legislation, no, the answer is no. But yes, we have been through that legislation because we are looking for opportunities in the legislation. And for a couple of reasons. Is one, where there's an opportunity that's a good one, but also hidden in the legislation where we find that there are parts of legislation that once it's discovered, they're going to make implementation of the law effective now. But it's just a general statement about Congress in general, that when you look on the legislative docket of what a congressman is, and I'm sympathetic to them because they just have an overwhelming job, and the life has become so complex, it's really hard for them to understand it. It's one thing in the Senate where you have a 6-year term, but in the House, every congressperson is running continually because they only have a 2-year term. And what they're having to do is run to get the money to get reelected again. So they have a pretty limited time in order to understand how complex these issues are. Yes, okay?
Since a large portion of healthcare is devoted to people in the last 6 months of their lives,
Yeah.
how are the other 10 countries that are ahead of us in terms of healthcare? How do they handle that?
There's not one rule for all of them, but certainly in the one I'm most familiar with in Britain, they have, I can't remember the name of it, but they have a system in which they deny care for things that they don't think are reasonable. Now, for example, dialysis in your last year of life, they won't pay for dialysis now. When they're having these severe financial constraints, plus they have an obligation to fund the care of other people not in the last 6 months of life, then they are making conscious decisions to deny or withhold care. Yeah. But it varies from country to country. Yeah. In the U.S., because it's a fee-for-service environment, we tend to do it because a hospital who keeps a patient on a ventilator for another 2 weeks gets paid for that now. And so it's a source of revenue for the hospital, and their costs are going to be covered. It's very hard in this country to have a policy decision that we're going to deny care. It's just almost impossible to do. Yes?
Talk, one of the data points you were looking at, comparing to these 11 countries,
Right.
was a system of care. You made the statement that the United States does not have a system of care. That implies, based on the countries that have been cherry-picked plus the United States, the system basically means the government runs or manages or otherwise mandates how the healthcare system works. Doesn't that then put your fingers on the scale basically to encourage government-run health systems rather than private-run health systems as we have in the United States?
Well, the United States has a lot of government-run healthcare systems. If anybody tried to take away Medicare from me, then that's a pure government-funded, government-run healthcare system for 45 million people. The VA is the same way. And the healthcare reform legislation is not about a run healthcare, but rather setting up marketplaces of private insurers to compete in the marketplace for those dollars. And you have to take country by country. Britain now has a two-tier, well, the UK has a two-tier system. And one is they do have a government-run health system that guarantees coverage for all citizens. But they have a second tier, which is a fee-for-service system, if you can afford to do that now. And I'm not sure what the term cherry pick meant, but these are just the 11 biggest industrialized countries. They were picked on the basis of what their record in healthcare is, not selecting one over the other. And that's obviously been one of the concerns of one side of the aisle, is not wanting a government-run health system now. But there are certain things the government is better at doing than the private sector is. The trouble with the private sector in a fee-for-service environment is that there's too much conflict of interest in terms of the amount of reimbursement that you're going to get. So to me, there's a balance between what is the role of government and what is the role of the private sector.